I'm Dr. Mackelaite. I'm from Renal Department 2. I think I worked with most of you guys. So I don't know if this is very high yield for boards, but most of you rotate at Jewish Hospital with me or Dr. Youssef on transplant rotation, so I think that'll be at least helpful practically. So there's a lot of people with end-stage renal disease in the United States. It's almost 500,000 right now. This is the last data. I just checked it yesterday. The most recent number that we have is 430,000 people that are on dialysis. The goal should be to transplant every one of them if they can tolerate it. And if they're the candidate, but unfortunately it doesn't happen. So there's 500,000 people who are on dialysis, and there's only 185,000 people who have transplant, which is actually much better than being on dialysis. There's a big number of patients on transplant list, current, active. It's 100,000 people. The problem is why not a lot of people get transplanted, and why the wait list is so long is that there's shortage of donors, both living and cadaveric donors. So I hope everybody has a donor sign on their driver's license. So first of all, getting a kidney transplant is better for the patient. They live longer if they get a transplant compared to staying on dialysis. They gain on average about 7 years of life if they get a transplant compared to staying on dialysis, but it also saves money. Transplant starts saving money after about 2 years on dialysis. So if patient goes beyond 2 years on dialysis, versus getting a transplant, it's more cost effective. So you save money and you save years of life. So everybody should advocate transplantation. I'll go through patient cases, and these are actually real patients. Maybe some of you have seen them in the hospital. The first one is she's a 27 years old African-American female with history of lupus, who was treated with Cellcept or mycophenolate mofetil in the past, but unfortunately now has worsening renal function, and her kidney biopsy shows that she has just a lot of fibrosis. So basically, her kidneys are burnt out. She has a functioning AV fistula, but has never had dialysis yet. And she would really want to avoid dialysis if possible, and has some potential living donors. But she thinks that she has to start it before she gets listed for the transplant. So is it true? Do you have to start dialysis in order to get listed, or? Yeah, so I see a shaking of the head. So you can get a preemptive transplant, and this is actually better. People live longer if they get preemptive transplant compared to getting a transplant after they start dialysis. So when somebody has a worsening kidney function, you don't only talk about dialysis, but you talk about transplant and start working them up for that. There are multiple types of kidney transplant. So we know about cadaveric transplant and living donors. Oh, okay. So, but there are different types of living and cadaveric donors. So some people think that they can get a transplant only from their relative, but it doesn't have to be a blood relative. It can be a neighbor, a friend from the church. So it can be either liver-related or unrelated. Now it is becoming pretty common, I would say. There's anonymous donors, people who read on the newspaper about somebody who's undergoing dialysis, or even read about a story on Facebook. We had a patient who had a living donor living donor kidney, which she found on Facebook. So there can be anonymous directed and undirected donor. We do also period exchange donation, and that's if you have a living donor, but it's not a match for you. Let's say you have different blood types. So you can do an exchange with another couple somewhere else in the country and get the kidney from that donor, and your donor will give a kidney to another patient. Cadaveric donors, you don't have to remember all these different names, but they come in different flavors. Not all cadaveric kidneys are the same quality. So there's standard criteria kidneys and expanded criteria kidneys. Standard are better than expanded, and standard last longer than expanded. So expanded criteria donor kidneys would be if it's a kidney from somebody who had high blood pressure or was older, like more than 65 years old, or died of a stroke or something like that. So they're not going to last as long, and you may want to give these worse kidneys to older people. Mm-hmm. If you have any questions, or if you want to pimp me, do that any minute. So we decided that she doesn't have to start dialysis. She can go ahead and get a transplant, and that's going to be better for her. So she has a potential donor. It's her cousin, 21 years old lady with no past medical history, who has never been pregnant. And here's some information about the patient, the recipient, and the donor. So first of all, blood type. Patient's blood type is AB, and cousin's blood type is O. So just based on that, do you think you can do the transplant? So ABO blood type antigens are very important in transplantation. These are the antigens that will elicit and cause rejection if recipient and donor are incompatible. There is ABO antigens in the transplant kidney, so the patient or recipient can make antibodies and reject the kidney if they get these antigens with the kidney. So if you give blood type O kidney to a blood type AB recipient, is it going to be a problem? You can you can think about that the same way as you think about transfusions. So if you can transfuse the blood from the donor into the recipient, they should be compatible for the transplant too. Now there are H antigen, positive to negative. Does that matter? So in transplantation, it doesn't matter. And that applies to all the organ transplants. So our H is not an important transplant antigen. You're not going to reject it if it doesn't match. And now the other antigen that is important in transplantation is human leukocyte antigen. You do not have to have the same HLA antigens, but the better the match, the longer the kidney usually lasts and less rejection you get. So could somebody calculate how many antigen match this is? We calculated for 6 antigens. What? Any guess? It's probably 3. So you just see which antigens are the same. So 2 and 2 is the same. B, 16 and 16 is the same. DR, 2 and 2 is the same. So 3 antigen match, which is not too bad. Does this 21-year-old bother you at all? Is there an age limit for the transplant? So there is. You don't want to we never take kidneys from kids. So most of the centers, 21 is the cutoff. Some centers have 18 years old of age as a cutoff. The thing is, if you take a kidney out of a young person, you can't really predict what's going to happen later in life, and they'll still have to live at least 60 years, hopefully. So you want to make sure that they're perfect candidates. And also, if she donates, she's 21 years old, she has never been pregnant, she might be pregnant, her risk of preeclampsia will be a little bit increased. So that's another. So you want to make sure that she has perfect health. So I mentioned before there's 100,000 people on a wait list for a kidney transplant. It's a big job to manage that wait list. You want to be on the top of the list to get a kidney, and to get to the top of the list, you have to earn points. So patients get point for each year being on the list. So the longer you're on the list, the higher you go up on it. Also, kids get a lot of points. They get 4 points if they're less than age 11. You also get points if you donated any type of organ in the past. Well, usually it's kidney. So we have one patient right now on the wait list who donated before in the past and now is ESRD and needs a kidney. So you really want to transplant them soon. And the wait time also depends on the blood type. Actually, patients are lucky if they're in Kentucky. The wait times are much shorter here than, let's say, on East Coast or West Coast. So just to give you a comparison here, probably the average wait time will be 2 to 3 years, and on East Coast it's 4 to 5 years. So that's the same patient. So you counsel patient about increased risk of infection after transplant, but you should also tell her about increased risk of what? Diabetes, cardiovascular disease, skin cancer, decreased survival after transplant compared to continued dialysis, or A, B, and C. Any guesses? F. No? What? Yes, that's right. Yay, we got one answer. So I mentioned it at the beginning that actually they live longer if they get a transplant. But there are some risks associated with transplantation. So everybody knows about infections, increased risk of certain cancers, but also the medicines that we use after transplantation, they increase the risk of diabetes and hypertension, and then, of course, cardiovascular. Oh, I'm sorry, not other problems. Now, the same patient, so for some reason her donor didn't pan out, it wasn't a good candidate, so she received a cadaveric kidney transplant. That was 2 antigen match, CMV positive to CMV negative, and I'm going to tell you what that means later. Transplant, and she had no complications. She had no delayed graft function, and her induction included alemtuzumab with solumedrol. That is what we use right now at Jewish Hospital. And she was placed on tacrolimus, mycophenolate, mofetil, and prednisone. And again, these are pretty specific medications used in transplantation, well, in some other diseases too. So I don't think it's a fair question to ask about it on boards. But basically, immunosuppression after the transplant, any type of organ, it's induction and maintenance. Induction is you give a very strong medicine during the transplant intravenously that is supposed to block your T lymphocytes, and it blocks T lymphocyte function for up to 4 or 5 months after the transplant. It can kill lymphocytes like thymoglobulin or alemtuzumab, or it can just block their function. And then everybody gets steroids, so Solumedrol, during the transplant and for a couple of days afterwards. And then maintenance is something that they will have to take as long as the kidney works, and they have to take it every day. And the most common combination still for immunosuppression is calcineurin inhibitor plus mycophenolate mofetil, plus minus steroids. Now, everybody tries to use steroid-free maintenance because everybody's afraid of steroids, obesity, diabetes, and things like that. This is just what shows what centers are using most commonly for immunosuppression. So TAC is tacrolimus or Prograf, and MMF is mycophenolate mofetil and Celcept. We have been using, the things change in transplantation pretty quickly. That's why it is exciting. So the new medicines are coming out, and now we're using some new medications. And when you round the Jewish Hospital and Transplant Service, you will see that quite a few people are not going to be on your regular MMF and tacrolimus, but we started using more of everolimus, which is similar to sirolimus, Rapamune, and the reasoning under that is that it looks like people get less viral infections. The other very promising medicine, which we try to use if we can, usually the problem is insurance doesn't cover it, and it is belatacept. We borrowed it from rheumatology. People use abatacept in rheumatoid arthritis, I believe. It is a T-cell co-stimulation blocker. And it is kind of convenient. You don't have to take it every day. It's just a monthly infusion. So you don't have to check its levels. And it takes a role of calcineurin inhibitor. And it doesn't have the side effects of calcineurin inhibitor. So a lot of our, well, the ones that can afford it or insurance pays, we try to put them on belatacept now. I mentioned before, but there's a lot of side effects from immunosuppressive medications, and I can imagine that this question could maybe pop up at internal medicine boards. So calcineurin inhibitors, which are still the most commonly used medications in transplant and in other organ transplantation, they have a lot of side effects. So they can cause hypertension. They're nephrotoxic if you run levels that are too high. They cause a lot of electrolyte abnormalities like hyperkalemia, acidosis, low magnesium. They cause diabetes. So it's not only steroids that cause diabetes after transplantation, but actually more probably calcineurin inhibitors. And then tacrolimus will cause hair loss, but cyclosporin will cause hair growth. So this is just a reminder of our patient. So she got a cadaveric donor kidney transplant, and I mentioned before that it was CMV positive to CMV negative transplant. So we're going to talk a little bit about CMV now. So CMV positive to negative, it doesn't mean that her donor had CMV infection at the time of the transplant. Actually, this just means that her donor had antibodies against CMV. So it means that the donor probably had infection sometime in the past and now had immunity to it. But the recipient was CMV negative. That means that the recipient doesn't have antibodies against CMV. So it means that she never had CMV infection in the past, so she doesn't have immunity. This is important because it determines the risk of CMV infection. Before we had prophylaxis for CMV, a lot of people would get that infection and mortality was very high. So things have changed significantly when ganciclovir, valganciclovir came out. So let's see. the risk of CMV infection depends on the antibody status against CMV of the donor and recipient. So the risk goes from low to high. And just to tell you, before the prophylaxis, if you were high risk for CMV infection, and that means if the donor had antibodies against CMV and you didn't have it, the risk of getting infection was close to 90%, so very high. But if you were low risk, it was less than 5%. So prophylaxis against CMV, everybody gets it after transplant, and usually it's 3 to 6 months depending on your risk. And it works. Now, this looks similar to something that you guys use in HIV infection. So they need prophylaxis for other things. So first of all, everybody goes on valganciclovir or Valsite for some time. You also have to prophylax for PCP pneumonia, and that's usually Bactrim. Thrush, usually nystatin for 1 month, and TB if they had positive PPD and they have never been treated for it in the past, so you have to prophylax for it too. So very similar to HIV. Now what happened to the patient again? So she does very well after a transplant, but 6 months afterwards she develops productive cough and fever. She goes to ER, and of course she gets levofloxacin and is discharged home. She comes to your clinic, and you notice that her creatinine now is 4.2 from normal, and potassium is 6.1. So not very good. So what do? Do a biopsy, because you think that she has rejection. You put her back on dialysis, creatinine 4.2, hyperkalemia. There's no way that kidney is going to recover. You start empiric steroids, or you check tacrolimus level. She most likely has tacrolimus toxicity. I thought I heard something. Yes, D. That's for sure. So all these are possible after transplantation. If you get a rejection, your creatinine is going to go up. You never treat empirically transplant patient for anything. It's very easy to do the biopsy. The thing is, the kidney is so close to the skin that you could do a biopsy without an ultrasound. You can feel the kidney, and so we do biopsies often. So never treat empirically, nothing. And definitely don't put her back on dialysis. It's all acute, and most of the things that cause acute kidney injury in the transplant are treatable. So, but I guess here we think we know the reason. She was put on levofloxacin, which is metabolized by the same CYP450 enzyme in the liver. That's similar to, I guess, warfarin. What happens to warfarin? A lot of drug interactions, and some medications will increase the level of prograf, and some will decrease the level of prograf. So we don't like when people start new medicines on transplant patients without telling us, so we always tell the people to call us if they start any new medication, because there is a lot of interaction, and it changes the level of the medicine pretty significantly. And these are not uncommon medicines. I mean, we use levofloxacin very often, so this clinical scenario is very, very common. Also, some blood pressure medicines, diltiazem, will do that too. So Dr. McCann's will be really upset if you stop or start diltiazem on their heart transplant patients. Then protease inhibitor, like in HIV people, will increase the level of prograf pretty significantly, and grapefruit juice too, and it is clinically significant. And then there are some medicines that will increase metabolism of prograf, so decrease the level, and then you can get rejection. And these are anti-seizure medicines usually, carbamazepine, phenytoin, and INH or rifampin. So we're done with patient 1. Another patient is 72 years old, African-American female, with a history of ESRD, who was on dialysis for 6 years prior to getting transplant. She gets kidney transplant, CMV positive to CMV positive, so she's moderate risk, uncomplicated course, gets discharged home, and then comes to the clinic, and her creatinine is 1.6. It's still continuing to decrease, but her potassium is 5.3, bicarbonate is 16, and phosphorus is 1.6, and calcium is 11.2. She is not on any phosphorus binders. You always have to check that when somebody is hypophosphatemic. But she was on phosphorus binders before the transplant. So what is wrong with her electrolytes? So she has high potassium, low bicarb, low phosphorus, and high calcium. Is it uncommon? It is very common. Basically, you will see that on every other patient after a transplant, even when their kidney is working. So can somebody tell me why she has low phosphorus and high calcium? If somebody can tell, I'll buy them coffee. Yeah, very good. I owe you coffee. So it's caused probably by secondary or tertiary hyperparathyroidism. So what happens? A lot of people, every other person gets hypercalcemia and hypophosphatemia, and it's from hyperparathyroidism. When somebody's on dialysis and has persistently high phosphorus, that decreases their ionized calcium and it stimulates PTH. That is secondary hyperparathyroidism. If that goes on for too long, parathyroids develop nodules which become autonomous. So it's similar to the primary hyperparathyroidism, but we call it tertiary. So now you give them a kidney that works fine, and there's no problem with retaining phosphorus, but they still have high PTH levels, so they act as if they have primary hyperpara. And they'll get all the symptoms. They'll get stones, moans, psychic overtones. They do get stones, and they get worsening kidney function, so you want to treat it. And basically you treat it as primary hyperparathyroidism. Everybody gets hyperkalemia. Well, not everybody, but a lot of people get hyperkalemia after transplant. And it's not only people whose kidney is not working, but who has normal kidney function, and it's caused by calcineurin inhibitors. Tacrolimus and cyclosporin will do that. Acidosis also from calcineurin inhibitors. And hypomagnesemia, pretty bad. They go pretty low, also from medication side effect. Okay, that's I think the last patient. So 9-year-old African-American girl, and I said these all people are real. There was a period at Cozier Children's Hospital when they had no nephrologist, so me and Dr. Youssef became pediatric nephrologists too. So this is a real girl. Who has a history of ESRD, secondary to post-infectious GN, and she got living-related kidney transplant at the age of 7. She comes to the clinic for follow-up with her grandmother. She's on immunosuppression with tacrolimus and nefprednisone. Her creatinine is 2.4, which is a really bad creatinine for a kid. Kids should have creatinines of 0.6, 0.5. Urinalysis shows proteinuria and white blood cells. And her grandmother states that she has been having trouble at school, and patient herself admits that the kids are calling her chubby cheeks, and she's a very active cheerleader. So what do you think might have happened to her? She stopped her medicines. So kids stop their medicines, try to avoid taking them because they don't like the side effects, especially steroids. So she stopped her medicines, and what do you think happened? She got rejection. I mean, if you stop medicine, you get rejection. The most common reason for rejection is non-compliance with medications. And that's what you see on her biopsy. It's even hard to tell that it's a kidney, but basically rejection is that your immune system attacks your kidney, so you see a lot of lymphocytes here attacking the tubules and interstitium. It's all blue, shouldn't be like that. So is it treatable, rejection? So people, or patients at least, are under the impression when you tell them that if they get a rejection, they think that's it, kidney stopped working. So actually, no. It's very treatable, especially if you treat it early. I mean, if it goes on for a long time, it's not going to be fixable. There are two types of rejection in all organ transplants, in liver, in pancreas, and heart, in kidney. It can be either mediated by cells, lymphocytes, they chew up the kidney, and the picture before showed that, or it can be mediated by antibodies. Cellular rejection is more common, and it's much easier to treat. Usually it responds just to intravenous steroids. Humoral or antibody-mediated rejection is much harder to treat, and the treatment is different. Steroids don't work, so we do plasmapheresis, which removes the antibodies, and you try to kill or block B cells to stop the antibody production. So usually we're rituximab, or we use bortezomib or Velcade, used in multiple myeloma, but it's harder to treat it. But luckily, it's less common than cellular rejection. Oh, I guess one more patient. Sorry. So this is a 53 years old Caucasian male who received altruistic living unrelated kidney transplant a year ago. And immunosuppression includes tacrolimus MMF. You notice that his creatinine is rising, and he has proteinuria. He has no diabetes, and he's definitely very compliant with medicines. His levels are always where they should be. So what do you do? Biopsy. It's very easy to do the biopsy. It's very close. And the biopsy shows that there's an arrow here. So this is something that is pretty specific to kidney transplant patients and doesn't happen to other people except for bone marrow transplant patients, but they get different manifestation of it. And this is a BK virus infection. So BK nephropathy, and basically what it causes, BK virus doesn't cause any systemic symptoms. No fever, no cough, no pneumonitis, no rash, nothing. The only thing that happens is your creatinine starts going up. It's from the polyoma virus class of viruses, is the same, similar to JC. And the treatment, they don't have a good treatment. If they get BK virus, it probably means that they're over-immunosuppressed, so you want to cut back on immunosuppression. Other organ transplant people can get BK nephropathy too, like heart transplant or liver transplant patients. So keep that in mind. And bone marrow transplant patients get hemorrhagic cystitis from BK virus, which can be pretty severe. Not so often kidney dysfunction. The last thing, so some cancers after a transplant are increased. And it's mainly skin cancer, but differently than in general population, where the most common cancer is basal, oh my goodness. So squamous cancer is the most common in transplant patients of skin cancers. Also lymphoma is increased pretty significantly, liver, anus, vulva, and lip. Breast cancer risk is not increased. So we have here 26 years old Caucasian male with history of transplant 7 months ago. He has diarrhea and he has positive EBV PCR. He has colonoscopy and biopsy, and he has monomorphic lymphocytic infiltrate. What do you think he has? So he has lymphoma in his bowel, and does anybody know the specific name for the lymphoma that is EBV mediated in transplant patients? It's PTLD. It's post-transplant lymphoproliferative disorder. It's not as common after kidney as after heart or intestine or liver, but still 1% of people will get it. And it doesn't always affect the, you get extranodal involvement in 75% of patients, so they can present with diarrhea many times and GI involvement. So that's PTLD after transplantation, 1 to 3%. And the more immunosuppressed they are, the higher the risk. And treatment is reduction of immunosuppression. Usually that helps. Also rituximab, and very rarely CHOP. And that is it.